Which edition this?
Yes, ma'am, we are good to go.
Good evening, everyone. A very warm welcome to all in this another very interesting and knowledgeable session of ACP India Case Files, a John Tucker Evergreen Award winning series. And today we have a panel of experts who are outstanding in their field. And I am sure we will gain a lot of knowledge by having such an expert panel team today. But before starting the session, please join me in welcoming our Governor, ACP India Chapter, Dr. Anuj Maheshwari. Sir's vision, Sir's guidance, and Sir's leadership has been a backbone for ACP India Chapter. And I would like and invite Sir to say a few words.
Thank you. Thank you, Preeti, and thank you all those who are involved in organizing this another edition of the case file. I welcome all ACP members as well as those who are not ACP members to join ACP and get the benefit of this wonderful program that is called as ECP case file. ECP case file is dedicated to the early career physician, and we try to make it more relevant and more useful for early career physician. This program is popular not only in India but across the world, and many people join this program from other countries also. Today we are having very special guest from Armed Forces Medical College in India, from Pune, and definitely I believe we shall be having a very good discussion, especially the case-based discussion on some interesting case what Dr. S.K. Singh is going to present. So without wasting much time, I request to all of you make the program start. Over to Amit.
Thank you, sir. I welcome all the distinguished faculties, our Governor Dr. Anuj Maheshwari and the program lead Dr. Preeti Singh. And this is going to be a very, very insightful discussion because we have a very interesting case coming up, and also a very good and engaging talk which is going to charity begins from home, how doctors should exercise. So over to you, Dr. Preeti, and wish you all the best for the program. Thank you.
I would like to introduce Dr. Kannan A, who will be moderating today's session. Sir did his UG from FMC and PG from MMC, diabetology from Annamalai University. He completed his Jocelyn Diabetes course and is an active task force member of RSSDI, ACE and ESTN. He did his fellowship in Diabetes India 2023. So over to Dr. Kannan for moderating the sessions.
Good evening, all. At the outset, I would like to thank our respected Honorable Governor, Professor Dr. Anuj Maheshwari, and also Dr. Amit Ji and Dr. Preeti and Dr. Kumar and Dr. S.K. Singh for giving me this great opportunity to be associated with our one of the prestigious platform of ACP India case files. We know that this is one of the important edition today. Today we are going to discuss on two important case scenarios. The first case scenario will be discussed by Dr. Professor S.K. Singh, and the second case will be discussed by Dr. Kumar. The first case will be on the important, which you usually see in our routine clinical practice. Usually in our routine clinical practice, we see a case of fever, any recurrent infection, cough, pyrexia of unknown origin. Routinely we do CBC and XHS and all. And we empirically we do some antibody treatment on the further we'll move more. And today we have somewhat very interesting cases. A tail of fungal infection in immunocompromised, or the truly rare or rarely diagnosed, which so going to be enlightened by one of none other than Professor Dr. S.K. Singh. He is the Professor of Medicine, AFMC Pune, and Professor of Medicine, Maharashtra University. He has multiple academic qualifications. He's MBBS and MD Internal Medicine of Pune. He's a fellowship in general infectious diseases. He's a postgraduate fellowship, diploma hospital and health management. He's a postgraduate fellow certificate in medical management. He is one of the fellowship in multiple areas of military as well as civil awards. He's a fellow of Indian College of Physicians. He had 3 FRCP from London, Edinburgh, and Glasgow and all. He's conducted many research projects and also publication, more than 60 publications. His area of interest are so peculiar. He's more interested on tropical diseases, diabetes, respiratory diseases, rheumatological emergencies, high altitude, combat medicine, bleeding disorder, and hemophilia. Now, I request Dr. S.K. Singh to do his deliberation on the rare care scenario in our routine clinical practice. Over to you, Dr. S.K. Singh.
Thank you, sir.
Allow me to share.
Ma'am, please allow me to share the slides.
So you can share your screen, sir.
Is it visible, sir?
Not yet.
Are you able to see the share screen button?
Yeah. It's.
No, we are not.
So we are not able to see the share screen button, sir.
Green button.
So there is a green button, share screen button next to the chat button.
At the bottom of the Zoom screen, sir, you will find the share screen option.
So just now I have made you the co-host, so now you are able to see, I think.
Can you see the green button now?
Green button is not visible as of now, sir.
The
Let's
participant
try.
chat, and in the middle is the share screen button.
I have make you as a co-host, so now you are able to see, I think.
It's not showing this green button. I'm just.
It's at the bottom of the screen. Next to participants chat and then share screen.
Can you send it to us on the mail, sir, or can you send it to the WhatsApp? We will share with
Yeah. We are just doing, sir. Just a minute. I'm joining from another computer, sir. Just a minute.
Right. Meanwhile, Dr. Kannan, you can continue with some discussion. And
Ankit, you can
Yeah.
give the demo on the
Yes, sir.
video call to Dr. S.K. Singh so that he can find the green button.
Sure, sir.
Dr. S.K. Singh has joined from the.
In the meantime, Dr. S.K. Singh, you please send your PPT to any of us, either Dr. Preeti or Amit, so that we can show it from ourselves.
So, dear friends, today we have an interesting case from Professor S.K. Singh. So, routinely in our clinical practice, we used to see a lot of fever cases. So, previously, our professor used to say any fever more than 5 days is significant. But the scenario has been changed. Even we are in the era of both practicing precision medicine, precision other things and all. We have to choose our the way of diagnostic procedure at the day 3 itself. So any fever more than 3 days is significant. So this is the area we want to consider now. This important case challenging we have to be presented by S.K. Singh. Over to Professor S.K. Singh.
S.K. Singh, sir, your slides are visible to us. Now you unmute. Your voice is not audible to us. No. Audio is not coming, sir. Dr. S.K. Singh, sir, audio is not, you are not audible to us. Please check your audio setting.
Sir, you can unmute your another device as well if you are using that.
You unmute the other device and present on this.
Sir, can you unmute your another device?
Yes, sir, we are doing it.
Yes,
Now,
now I can hear you.
Now we are able to hear you, sir.
Yes, got all. Yes. Good evening, ladies and gentlemen. And at the outset, I would like to thank Dr. Anuj sir, Governor Acp India chapter, Dr. Amit and Dr. Preeti Singh ma'am for giving us an opportunity in this Acp India case file. So today we are going to discuss a case, a tale of fungal infection in immunocompromised, truly rare or rarely diagnosed. As we all are aware that opportunistic infections in immunocompromised patient is always challenge for the internist and it can lead to life-threatening complications in the patients with adverse outcome. So today we will be discussing an opportunistic infection which is rarely seen. So my case is 34-year-old male who is resident of Halang, Manipur. He is educated up to 12th standard and informant is self and wife and reliability is fair. He presented to us with chief complaint of breathlessness on exertion and weight loss of 5 months. So, patient complained of dyspnea on exertion, which was insidious in onset and gradually progressive, and worsened from MMRC grade 1 to grade 3 over a period of 5 months. Patient also complains of unintentional significant weight loss with decreased appetite. There was no history of any fever, cough, night sweat, chest pain, palpitation, pre-syncope, syncope. There was no history of any hematosis melina. There was no history of any renal involvement or GI involvement. So coming to the personal history, there was no history suggestive of he consumed basically coming to the past history, patient is a known case of PL-HIV. He was diagnosed in July 2016 during evaluation for weight loss and he was started on first line ART, that is PLE. His initial CD4 count was 96. However, at that point of time, the viral load was not available. So mode of infection was unknown. There was no history suggestive of any chronic illness. Personal history, like he consumed mixed diet and there was no addiction per se. On the family history front, the spouse was HIV status was positive and she was on ART. Children were negative. So treatment history, he was started on therapy for tuberculosis 2 months back at a peripheral hospital. There was no improvement in the symptoms. General examination, his BMI was 17.1 kg per meter square. He was hemodynamically stable. Pallor was present. Oral thrusts were present. There was a skin lesion in the form of verruca plana over dorsum of the hand and central umbilical patch over the face. So here you can see these are the seborrheic dermatitis features, and here we can appreciate these umbilical lesions which is shown. Systemic examination, per abdomen, patient was having organomegaly, hepatosplenomegaly. Other systemic examination were unremarkable. So, at the end of history and clinical examination, just to recapitulate, we have 34-year-old male who is a native of Manipur and a known case of retropositive. He presented with progressive breathlessness on exertion with significant unintentional waist loss over 5 months. So at this point, the possibilities which we considered, first was pulmonary tuberculosis. Likely it is MDR because this patient was already on AGG for 2 months, and there was not much significant response with the AGG. So MDR was one of the possibilities which we thought of. Non-tubercular mycobacteria was the other possibility. Then we thought of vaccinated fungal infections like histoplasmosis, cryptococcus. Lymphoma was also one of the possibilities in view of historical findings. And leishmaniasis was also considered because it hails from northeast and there was significant heterogeneity in this case. So the investigation which was done in the peripheral hospital, it revealed basically patient was having pancytopenia. Here you can see HB of 9.3 with TLC of 1700. He was having class amyloiditis and CD4 count was 30. This is the investigations which was the same like USG abdomen again where we can appreciate splenomegaly and triple phase CT which was done. It was suggestive of mesenteric lymphadenopathy 2.5 into 2.1 centimeters. Chest X-ray revealed minimal fibrosis left middle jaw and HRCT chest. There was thick walled cavity lesion in left upper lobe and mediastinal lymphadenopathy was there. So, to further add the investigations finding at Peripheral Hospital, here we can see all the three the cell line, HP, TLC, and platelets. There was a finding consistent with pancytopenia with anemia of chronic disease. So, in view of persistent pancytopenia, hematology consult was also taken at Peripheral Center. However, pancytopenia was attributed directly to HIV infection and he was advised follow-up. The case was discussed with our center and he was advised to transfer to us for further management. These are the investigations which was done at our center. Here you can see HB of 6.4. Investigations at our center revealed consistent pancytopenia with anemia of chronic disease. His HIV RNA viral load was 4.48. He was also screened for other opportunistic infections. So he stooled for a modified Janssen stain, acid fast oocytes resembling cryptosporidium was seen. Other viral markers like SVSAG, NTHCG, and VDRL was negative. His serum TRAC was negative. RK39 antibody for HIV was negative. Torch screening was negative. And he was also subjected for sputum for ARB, sputum for CBNAT, and BAL for CBNAT, which was negative in this case. This is the CCT chest and abdomen, and here you can see there is a thick walled cavity with subsegmented consolidation in the apico-posterior segment of left upper lobe. And also, he was having splenomegaly, which can be appreciated. CCT abdomen revealed there was basically mesenteric lymphadenopathy. So, based on this CCT chest and CCT abdomen, these findings in a given clinical scenario likely it represent infective etiology. So, in view of persistent pancytopenia, significant hepatosplenomegaly, and inadequate response to AGG, we went ahead with bone marrow study in this case. So here you can see in the bone marrow the aspirate. This is the hypercellular aspirate. These are the histiocytes which we can appreciate here in 400x magnification. You can see histiocytes. On further magnification to 1000x, we can see the intracellular hist form that is visible here. You can see the intracellular hist form. And on further this bone marrow aspiration, the fungal element here we can show it is sparse positivity is seen. On further, the Gomori becoming silver stain. It is positive. It is used for demonstration of polysaccharide contents of fungus. Brown black staining fungal cell we can appreciate here, which is due to deposition of reduced silver. So genus stain both live and dead fungi as compared to the past. This is the bone marrow biopsy. Here you can see mesophilic stiffening, platelet clumps, polychromasia. Hypercellular marrow can be appreciated. Plump histiocytosis in same bone marrow this biopsy, and this hypercellular marrow with morphologically normal hematopoietic stem cell that can be appreciated here. Here you can see there is a intra-histiocytic is formed, and these clumps inside the numerous histiocyte as well as extracellularly. So past positive is formed. This is the highlighted large cluster of distinct deep magenta staining of each resembling bunch of grapes, and these error findings are diagnostic of disseminated marrow penicillinosis. So final diagnosis was disseminated marrow penicillosis, that is the IS form, and it is suggestive of disseminated marrow penicillosis. We further go ahead with the clinical sample for the fungal diagnosis, and generally what we do, if there is a clinical sample, that is bone marrow aspirate, we subject them for staining as well as culture. So for staining, QH, mount, gram stain, GIMSA and GMS is supposed to be subjected, and culture is being done on SDA at high and low temperature, that is 37 degree and 28 degrees centigrade. So this depicts the processing of a clinical sample for fungal diagnosis. So initially, colonies were white in color, here we can appreciate, with a red pigment diffusing in the media, which was observed on day 1. And pasty colonies were also seen with red pigment. Here you can see this wave image of this red halo. So on this lactophenol cotton blue, these sample of bone marrow aspiration were inoculated in several dextrose agar, and at 37 degree, these pasty colonies were obtained without diffusible red pigment. So here we can see these are the, it seems like the broom, and these all are the, there is a style, there is a medulla, fillets. So as far the species speciation is concerned, we have finally concluded it is a case of Teloromyces magnifi, which was earlier known as Penicillium magnifi, and our final diagnosis was PLHIV with disseminated fungal infections, that is Teloromyces magnifi, which was biopsy and culture proven. So based on this diagnosis, our patient was started on amphotericin B at the dose of 200 milligram OD for 3 weeks. He was also started on tablet tenofovir 300 mg with lamivudine and efavirenz. Ceftriaxone and azithromycin was also given as per the prophylaxis. And apart from that, we have maintained this amphotericin chart where we can see, because we have subjected this patient for almost 3 weeks. And over 1 week of treatment, here we can see, because of the deranged urea and creatinine, his amphotericin dose was modified, and subsequently the dose was adjusted, and he has been given this antifungal therapy for almost 3 weeks. After this course of treatment in the hospital, our patient was symptomatically better with improved appetite. He gained weight around 59 kg. There was regression in the size of spleen, and also regression in the size of liver. There was clearing of skin lesion over the face. Here you can see these blackhead lesion and seborrheic dermatitis in this case. There was disappearance of these skin lesions. The CCT abdomen, which was repeated at our center, here you can see there was basically reduction in the size of this cavitary region. You can appreciate here. And other hematological investigations which was done at our center over the course of 2 months, here we can appreciate there was this pancytopenia picture has also improved gradually over 1.5 to 2 months after initiation of the treatment. So further, our patient was switched to second line ART, that is dolutegravir, lopinavir and ritonavir, and he was started on long-term oral itraconazole therapy as maintenance therapy, because in case of penicillosis, we are supposed to start the patients on maintenance therapy after induction therapy. So, to summarize about our case, just a brief overview of this Pteromycosis marneffi, which is previously known as penicillosis. It is being recognized as a major cause of HIV-associated opportunistic infection. It's a dimorphic fungi which leads to life-threatening mycosis in immunocompromised patients. The prevalence is surpassed only by TB and Cryptococcus, and mode of transmission is inhalation of Conidia, which was released from plant and soil. So these are the geographical distribution of this fungi. So in India, the main endemic area is Manipur and northeastern state, and apart from that, in Southeast Asian countries like Myanmar, Thailand, Cambodia, Vietnam, this is very prevalent. Around 100 cases reported worldwide in non-HIV setting, and Bamboo rates, they are the carrier, and the mortality can be more than 90% if it is not treated. So there are few review article on the epidemiology of this penicillosis, and here there have been few studies, almost 40 cases which has been reported from Northeast about this penicillosis. This, you can see these bamboo rats, and they are very common in northeastern state, basically in the state of Manipur. The clinical features remains fever, malaise, curve, dyspnea, weight loss, lymphadenopathy, organomegaly, hepatosplenomegaly, anemia, thrombocytis, as well as thrombocytopenia. The clues in this case can be if the CD4 count is less than 100, if the patient is having some skin lesions like molluscoid lesions, cavity lesions on the X-ray, and definitive diagnosis is based on bone marrow aspiration and culture on standard bacterial blood culture media and ST. The average time for culture positivity can vary from 4 days up to 14 days, and thermoregulated dimorphism, that is mode to yeast conversion, is key diagnostic features. And because of the limitations of the mycology lab, basically it is just the tip of iceberg, and most of the centers we are not able to actually really diagnose this opportunistic infection. So this is again a state mount which is ready for microscopy, and here we can see after this preparation of state mount, it will give appearance of like a broom, and that will be definitive diagnosis for pteromycosis. So the last part of my case, that is treatment recommendation. So ideally, it has got 3 phases: induction phase, consolidation phase, and maintenance phase. So in induction phase, liposomal amphotericin B has to be given with a dose of 3 to 5 milligram per kg per day for 2 weeks. And the alternative therapy can be voriconazole can also be given. In consolidation phase, itraconazole can be given 200 milligram per hour twice daily for 10 weeks. We have been continuing our patient with the consolidation and maintenance phase. And maintenance therapy or secondary prophylaxis with itraconazole 200 mg per hour daily can be given in this case. So with this, I have finished my case presentation. Any question or discussion, I am ready to take over any questions. Thank you very much.
Thank you very much, sir. It was a wonderful, interesting case scenario that is very difficult to diagnose also. See, what is the message you are given here? So any subject with a skin infection, with a low-grade respiratory infection, and also the background of any immunocompromised state leading to opportunistic infection, mainly fungus infections. The most commonest fungus will be aspergillosis, streptococcus, then the Candida albicans, and rarest among the Telromyces. So in this case, the patient had the pancytopenia with the background of HIV, and he was showing the impact of the thick-walled cavities in his X-ray. So, dear friends, the message I want to render here is any patient in your clinic with a low grade of symptoms and thick-walled cavity usually will be subjected the patient for ATT. Our purpose X casing was tried with the ATT empirically for 2 months, which HRE is there, but the radiological improvement was not seen, and the hematological improvement also was not seen. And he referred the patient to the hematologist, and he was finding a pancytopenia, and therefore he was advocating for the bone marrow aspiration cytology. There are 3 ways of approach here. We have skin approach, we have lymph node approach, and we have this bone marrow approach. This bone marrow controls the presence of this rarest fungi, which have been the infected host from the bamboo ras, which is usually prevails in the southern China and our own eastern India, especially in the Manipal side and Southeast Asia. Especially, there is one doubt for me, whether the patient had any travel history to China or any Thailand like that, any travel history of thing he had. Sir, you are muted, sir. Singh, sir, you are muted. Please unmute, yeah.
In Southeast Asia country, but then in Indian subcontinent, also in Manipur and northeastern state, it is very prevalent, sir. Because in Manipur, we are getting a lot of HIV cases, retro cases, and in this immunocompromised setting, because of their climatic conditions, this opportunistic infection is very common, sir. In the setting of HIV-1 infection with CD4 count, say less than 100, patient presenting with these unexplained pancytopenia and cavitary lung lesion, it should be evaluated for this disseminated fungal infections like telleromycosis. And since the like in India, we being the endemic TB country, we always think of just we give presented and we start the patient on ATT. But then in this setting, we need to actually do further investigations. So bone marrow studies should be done to confirm the diagnosis. Delay in diagnosis adds to the morbidity and mortality, which remains high, and even with the antifungal therapy in this scenario. So this case also highlights the importance of some drug interaction between anti-tubercular therapy and antifungal and ART therapy. Though India is a TB endemic country, but as an internist physician, we should keep in mind that invasive fungal infections are an important differentials in the immunocompromised host, and we should not leave these patients on just ATT, but these are the cases which require further evaluation. So that's why in this case, once there was no improvement in the clinical condition of this patient, so we have stopped the ATT and we further investigate this case, and it proves to be a case of rare disseminated fungal infection, and he also responded to the treatment.
So in this case, why we have not obtained the opinion from pulmonologists? Because this patient, one of the indication for a bronchoscopic evaluation.
Sir, we took the opinion of pulmonologist also, sir, and when he was referred to us, so sputum for AP3 samples and sputum for CV9, it was negative. Then we go ahead with the BAL, sir. Bronchoalveolar lavage was also done, sir, in this case, and this BAL for CV9 was also negative, sir. So we took pulmonologist's opinion also. So TB was ruled out. And based on this bone marrow aspiration and biopsy finding, which is 100% sensitivity in case of these disseminated fungal infections, we have narrowed down our diagnosis to this disseminated infection, fungal infections.
So you started the patient a single monotherapy of antifungal like amphotericin B, or initially you itself you go for combination therapy with amphotericin B and itraconazole, or you combine with voriconazole also, sir. You combine the triple drug.
Sir, ideally, initially we should subject this patient for injectable, sir, antifungal like liposomal amphotericin or conventional amphotericin B is a good option, and this is the initial phase. And then in the next phase, like after induction, the consolidation and maintenance phase has to be. Basically, injectable has to be initially started. It is followed by the induction phase and then the maintenance phase. So initially we have given amphotericin B. There was marked improvement, and after that we have started induction and maintenance phase in this patient. Actually, we should not combine, sir. First, we should go ahead with the induction phase, and then we should go ahead with the add-on phase.
So, how long we have to continue this maintenance phase of both amphotericin B as well as the itraconazole for these patients?
So, generally, this consolidation phase is supposed to be for the 10 weeks, sir, in this case, and maintenance phase is supposed to be, it is 200 mg OD daily, it has to be given, and we can continue it from 3 to 6 months, and at the same time we need to monitor the case also.
So these are the molecules will have the high burden of the liver enzyme, OT and PT. Whether you did a screening of every month of OT and PT while on amphotericin B and itraconazole?
Pardon, sir, liver steer. Can you repeat it, sir?
I'm asking
Can
about.
you repeat your question, sir?
Professor SK scheme, I am asking about the SGOT, SGPT evaluation. Why the patient on amphotericin B and itraconazole, because both are hepatotoxic molecule. These patients already having the elevation of both therobiological markers, SGOT and SGPT. Whether we want to access a patient every month for screening to avoid anything for liver failure like that, because he is already having the immunocompromised state.
Yeah, true, sir. In this case, like when you started on ART therapy and because of this penicillinosis, our patient was having mild transaminitis. His level of OT and PT was ranging from 60 to 75, sir. So, and this may be contributed just due to per se penicillinosis. So, while starting on amphotericin B, we are actually maintaining this this amphotericin B chart, and there was not much surge in the level of SGOT and PT. His OT and PT remains in the range of from 50 to 60, sir. So because we being the disseminated infection, we have to start the patient on aggressive treatment. So we continue with the treatment. There was not much range in the AST and ALT level. However, there was the range in the level of urea and creatinine. Patient was having azotemia, and for that we have modified the dose of amphotericin B. But sir, having said this, what was your point? Because the patient, he was already on first line ART, and he had all the features clinically and biochemically features of this penicillinosis. So we should be always very vigilant, and we should be alert as far as transaminitis is concerned, because they can further lead to liver failure. But in our case, there was not much rise in the case of AST and ALT. His AST and ALT level remains more just 1 to 1.5 times than the borderline of upper limit of the normal, sir. So we continue the treatment with the amphotericin B in this case.
So since we know that these bugs are more predominant while during the rainy season, how does the impact of this patient during the rainy season or summer season?
Yes, sir. Actually, if you go ahead with the epidemiology of this case, basically this wet area or rainy season, so the mode of transmission is it's very rampant, sir, and because it's a fungus, it's a dimorphic fungus, sir, so they actually provide the suitable environment for these things. So in northeastern state or whatever Southeast Asian countries where this case is more prevalent, they actually they provide the ambient environment for the growth of these dimorphic fungi. So this seasonal variation, that is rainy season, as well as the geographical distribution. Like if you find this Manipur, geographically it is more akin to the Southeast Asian countries, like where it is more prevalent. So I think it has this geographicality and as well as the seasonality, it has a lot of role to play as far as the dissemination of this infection is concerned, sir.
Thank you very much, sir. It was a wonderful deliberation on the rarest case. And dear friend, there is one message from this point of case scenario. This is a case which is usually routinely seen in clinical practice. Any patient with the background of immunocompromised state, we always should think of opportunistic infection. That is the message we want to render from Professor S.K. Singh. Thank you very much, sir. Thank you for the wonderful deliberation. So, dear friends, next we move on to the next interesting topic, which is very important for our clinical scenario. That is on the exercise. You know, the exercise plays an important pivotal role in all the management, both metabolic, non-metabolic, communicable, non-communicable, everywhere. There is one quote right from the period of Hippocrates. Lifestyle plays a pivotal role. We could give some individual the right amount of nourishment and exercise, not too little or not too much. So we always should practice the algorithm properly. I want to implicate the exercise regimen properly to our patients, because exercise is the center core or all the metabolic dysregulations. Now we have my friend, my eminent speaker, going to talk the role of exercise for the doctors, by the doctors. Over to, before that, I want to introduce, it's a great pleasure and honor to introduce Professor J.S. Kumar. He is MD and GD Australia and FRCP from Edinburgh. He's one of the Associate Dean of SRM, is the HOD and Professor of Medicine from SRM Medical College, Chennai, and is member of American Diabetic Association since from 2004. He's a live member of IDF 2006, and his other one, the RS is a member of since long way. He's a member of American AS since 2007. He's a member of EASD, and is a live member of Diabetic Food Society of India. He's a member of our own Endocrine Society of India, and also his publications more than 26 in his peers. Over to you, Professor J.S. Kumar, sir.
Thank you, Dr. Kannan, and thank you, Dr. Anuj, Amit, Dr. Preeti, and wonderful talk on a rare infection by Dr. S.K. Singh. Can I share the slides? Are my slides visible?
Yes, sir, visible, sir. Put in the full point mode, sir. Full mode.
Yeah.
Yes, sir.
Okay. So my talk would be just a lighter one, not too much dwelling on hardcore medicine, academia. This is more for a lifestyle. And I have coined this, I haven't retitled it with permission of yours, Dr. Amit, as well, that exercise prescription by doctors and for doctors. My agenda for the next 20 odd minutes would be like, we'll talk about the cardiovascular risk among physicians, what sarcopenia is it, and how physical activity and exercise is going to address sarcopenia, what are the different types of exercise, a word or two on snacking, but this time it will not be on food, but it will be on exercise snacking, especially when it comes to resistance exercise, and a couple of slides on osteoarthritis, because that is the commonest excuse that any person can say, that because why he is not exercising. A, lack of time. Number two, it would be some issue with the mobility, so especially with the joints. So if you look into the cardiovascular risk among doctors, you can see that advancing age, male gender, and being a doctor itself is associated with high risk, and the associations are statistically significant. This again is a study done in our own place in the Tamil Nadu in 2016, where they found that 55% of the healthcare providers were at increased risk of CVD just because of physical inactivity. And almost 50% of doctors were having high risk for CVD when they compared between, in a medical college, between the staff nurses, as well as staff nurses, as well as doctors. Among the healthcare providers, as well as the non-health workers, 10% of the nurses and doctors had dyslipidemia, 7% of them were obese, and especially when you are taking 30 as your BMI. Now you know that 30, probably 25 and above, is being considered as an obesity index for South Asians. Do healthy doctors deliver better messages for health promotion to their patients? This is always a kind of a situation that we are now in. Patient always sees the features of a doctor. So the personal behavior changes among doctors and better training of medical doctors on a personal health diet as well as lifestyle are likely to contribute to improve the behavioral counseling. Normal BMI physicians compared with overweight obese physicians counsel more frequently their obese patients on weight loss. And they also agree that physicians should be role models by maintaining a healthy weight, and they should be probably exercising regularly. Doctors who are highly physically active are more likely to spend more time counseling on exercise. And doctors, as all of us know, that we are vulnerable subpopulation. A doctor in India is more twice likely to develop CVD and stroke than in general person from the general population, despite an early access to healthcare facilities and first-hand knowledge. Many doctors are also unaware of their own blood pressure and their cholesterol levels. Occupational related stress could have led to high incidence of blood pressure, obesity, consequently leads to risk of CVD and stroke. Apart from that, depression and high suicidal rates are also much higher among the medical practitioners than compared to general population. So the risk factors for non-communicable disease could be always starting, which is a vicious cycle: anxiety, depression, chronic stress, post-traumatic stress disorder. Because you know that we all know that litigation is very common nowadays in India. For a trivial reason, we have been dragged to the court, and all this produces a lot of stress. And media are also not very, they are totally against the medical professional, even though we may be right in every account, but they paint us in a very bad picture. So this can all lead on to stroke, heart failure, cardiovascular disease, metabolic disease, and coronary artery calcification. So now let's talk about the subject that has been, we all know, but we don't talk too much now. My passion is now on this particular disease entity called sarcopenia. Sarcopenia primary is an age-related, so we call it as a primary sarcopenia, where there is a decline in the skeletal mass as well as function. It all starts with the age of 30, where the muscle mass decline is almost 3 to 8% per decade. But as the patient ages after the age of 65, the people start losing around 1.4% of their muscle mass and 1.4 to 2.5% of their strength every year. With IT field and post-COVID, the amount of time spent on mobile as well as on seeing Netflix, the sarcopenia has also now set in very young, in youth itself. So physical inactivity at much younger age. And even in pediatric population, because of congenital and perinatal factors, vitamin D deficiencies, various endocrine disorders, gut microbiota dysbiosis, you can get sarcopenia even in the youth. So even though sarcopenia was established in 1989 by Irving Rosenberg, there was no kind of a tool that to assess sarcopenia. It was in 2014 by the Asian Working Group of Sarcopenia that first had a consensus meeting and defined sarcopenia, which was again updated in 2019, by which they found that the low muscle strength could be defined using a dynamometer, the hand grip, jammer hand grip strength of less than 28 kilogram for men and 18 kilogram of women. This has been particularly done because we had an European guidelines. But when you look at the body frame of an European versus with Asian, we are always on the lower side when it comes to BMI. But our free fat mass was much higher than a European. This was eluded very well by the so-called YY paradox by Yannick almost in the late 1970s. So that's where we have an Asian working group for sarcopenia. And criteria for low physical performance is looking for a 6-minute walk of less than 1 meter per second or 5-time chair stand test of more than 12 seconds. That is the criteria for looking at the physical performance. And this is very easy performed, no high monetary equipment of very high cost is required for looking for sarcopenia. For research purpose, we have DEXA, but for screening in your wellness center, bioimpedance scale is much better off. Less than 7.7 kilogram meter squared for in men and 5.7 for women are being taken as the appendicular mass or a height adjusted muscle mass. And we know that both, since we are the second capital next to China when it comes to diabetes. So with sarcopenia also, with patients aging, elderly people more, are having access to health. We have this sarcopenia also begetting diabetes. So this is a kind of sarcopenia because diabetes, and diabetes also because sarcopenia. So we need to address both sarcopenia and diabetes together. And we physicians being physically more inactive, I think our sarcopenia sets in much earlier than, and rather it accelerates much earlier than the age of 60 or 65. Way probably in the age of 50 to 55, itself sarcopenia comes in amongst physicians. So if you look at the how to address this problem, this is my second part of my talk. So we look into the physical activity. Physical activity defined as any kind of activity which is done without any purpose. But when it comes to exercise, it involves structured activity to improve certain aspect of fitness. You do it with a purpose. There is a focus in our mind that I need to do 30 minutes of walk, 20 minutes of walk. For us, since I have to lose some weight, I need to make myself a cardiorespiratory, much more fitter person. If then we have that kind of thought process happening in our mind, that is called exercise. This can be categorized into light, moderate, vigorous based upon how based upon the intensity. And how do we look at the intensity is based on certain how we feel it subjectively. For example, if I'm able to walk without not sweating too much, I think that would be probably one of the lightest walks, just a casual stroll in the park where you have we do calculate all this measure exercise in the form units called METs, metabolic equivalence. So it will be somewhere between 1.6 to 3. Anything less than 3 is being taken as light exercise. When you are doing nothing, just sedentary, just now that we are all watching this show, we are just doing nothing at rest. So we are our body, the amount of exercise that is being done because of the basal metabolic rate is less than 1.6. That is sedentary activity. But if you want to do a little more, if you are going to hum a tune and then walk quick, maybe not, maybe we call it as a jog or a brisk walk, we may be expending somewhere between 3 to 6 minutes, which becomes a moderate exercise. Vigorous will be out of breath, means we may not be even able to finish off a sentence while walking. That becomes more than 6 minutes, around 6 to 9. But then if a sprint is there, you see a stray dog coming ferociously towards us and we just run out of fear or fright, that will become like a high intense exercise that is more than 9 minutes. So these are the different ways how which we can judge our own activity. So whether it is light, moderate, vigorous. And what is the exercise program? What the WHO says for every person, and doctors are also included in that, that we need to have at least 150 to 300 minutes of moderate intensive aerobic physical activity, be it running, jogging, swimming, stationary cycling, whatever it takes. So whatever is feasible to us within our busy practice life, definitely we should do it. If we have an inclination, like Professor S.K. Singh, who is in the army, where they have been already trained during their young age itself, during their MBBS program or post-MBBS graduation, and they have the facility, you have the facility for a track and field is available. Definitely you can spend on much more time. So at least we need to have 150 to 300, and on which 2 days at least we should do strength training, because aerobic exercise is not the answer for sarcopenia. Aerobic exercise can be an important factor for cardiorespiratory fitness, but it is going to be the resistance of the strength training program that is going to address sarcopenia. So aerobic exercise, I'm not going too much on the science or the physiology behind it. It's going to be a very light topic, so I want to keep it like that way. What does it do is that it improves the mitochondrial strength, because mitochondria per se is the most important cell that you can think of in the human body. When it comes to aging, when it comes to metabolic disorder, you call it diabetes, everything starts with a poor mitochondrial health. It's the pure mitochondrial health that ultimately acts on the beta cells, prevent insulin exocytosis, leading on to leading on to diabetes. So if we are able to take care of our mitochondrial health, it improves the mitophagy or the autophagy that we call about, and it definitely addresses sarcopenia a lot. So what about strength training? It improves by doing resistance exercise program. It improves our mobility. It improves the motor unit integrity. Definitely the balance improves, and definitely there is going to be improvement in the nature of the fiber. We do have two kinds of fiber, the slow twitch fiber as well as the fast twitch fiber. Fast twitch fiber is what takes care of our daily activities, which requires a lot of mitochondria and a lot of ATP. So slow twitch fibers are the endurance type of program. Lambe safar ka ghoda. So if you want to do a marathon, you always look for the slow twitch fibers, which improves with endurance. But for the fast twitch fibers, it is always going to be the resistance training program. So we need to have a combination of both. Now let us see how do we prescribe ourselves. So here is the slide I have given for an older adult. It can be an older physician. We need to consider these parameters. First, it will be the training frequency. So F stands for the frequency, and you have to look at the what type of exercise selection. So whether it is a lower body or an upper body, as you know that we need to have at least 2 sessions per week. So then you look at the intensity. So it can be a lower body. Lower body you use squats, half squats, knee extension, leg curls, calf raise. Upper body can be chest press, a seated row, or a pull down. And these need not be done in the gym. It can be done at home. Definitely post-COVID, we had a lot of YouTubes for the naive people, which can be done at home in an ambient atmosphere or between the clinics. In your busy practice, you have a break. For example, a 20 minutes break, I will definitely tell you on a slide where you can do this kind of exercise snacking in your practice itself without venturing out of your clinic. Exercise intensity is very, very important, because when we start as a naive, we have to be very careful about the exercise intensity, because one wrong, when with the urge of doing much better or a peer pressure that I want to do X number of times, that can be probably detrimental to the heart as well as probably to the muscle. So always start slow and increase the intensity over a period of time. So we can use our heart rate as one of the way of looking at the intensity, or as I said initially, you're looking at the tune, whether you can hum, whether it's a light, moderate, or vigorous. So all are the perceptions that you feel while doing exercise. So if you are pant of breath, when you're out of breath, means it's vigorous. So there is a Bjork score of RPE where you can do the scale like 6, 8, and 10. That probably later on, once you start getting the feel of doing it, that's very first you want to do it, then you have the start feel of doing it till it becomes a habit. Then the repetitions, the volume, exercise volume, how many sets you do and how many repeats you do. For example, you want to do your upper body exercise, you want to do your, for example, your arm, then you can do your biceps curls or the triceps. So you do, one pull towards the body and one away from the body. That will be one repetition. So if you are going to do it 6 times, that becomes 1 set. So if you are going to do with a break in between, that is the rest period, you again repeat it. So that is the 2nd set. Then you give a break of 30 seconds or 60 seconds, repeat it, that becomes the 3rd set. That's how we do about the repetition when it comes to resistance exercise. This is what a busy physician can do. You don't have to, you can do your within the clinic itself. Ask for a small break in between, or when the patient doesn't come or you have some time, you need to allocate where you can do. So traditional exercise is going to the gym, you do a major workout. It can be around 30 minutes or 35 to 40 minutes after a warm up and all. So the session is actually a longer one, and frequency is maybe probably 2 times a week. But what I am looking at for how can we make it much more feasible for a busy physician is to do minimal dose of resistance training rather than a traditional dose. So if you look at the cartoon to your right, you can see that the exercise snacks, they are low in intensity. So number of exercise and the number of exercise and sets are low. You just have to do around 2 exercises per muscle group, 2 sets, not the repetition of 3 or 4 sets, just 2 sets, and duration will be less than 15 minutes, 10 to 12 minutes. But then the frequency is higher. Instead of doing 2 sessions, you may do it on every day, 5 to 7 days a week. Whenever you have clinics, you'll be doing it during the clinic day, within the clinic. So it will be because you're doing very short burst but you're doing it repeatedly over the whole week. And the load have to be, depending upon body weight, you can use a very low weight. So you can use your own body. It's called functional training. You can use your own body to use for planks, push-ups. So these are the kind of exercise that you don't require any equipment whatsoever. And whatever little space is there in your clinic can be used for doing planks and push-ups as well as squats. You don't have to use any weights. So weight is not required or minimal or no equipment. This is the ideal for any physician, provided they don't have an severe cardiac issues or severe joint mobility issues or severe osteoarthritis. So if you start early, I think we can do justice. And we talked about stroke, we talked about depression, we talked about suicidal thoughts. Exercise definitely improves the sense of well-being. Body has a lot of cannabinoid receptors. So after doing exercise, we always feel pumped up. We gives a lot of high fives during our run, or as soon as run is over, our anger management also improves. So no more too much shouting with my postgraduates now compared to what I was before when I didn't take exercise and way back in 2011 and 12. So exercise improves the mood, sleep, interpersonal relationship improves, it reduces stress and anxiety. Along with that, nutrition supplement is very, very important. Just a word of this. Nutrition supplements, when I say, it can be supplement in a natural form. You don't have to buy a branded whey protein from outside. Probably sprouts, tofu, paneer. Non-vegetarian, always you have in egg whites, chicken. So lean meat is very important. We should avoid the red meat because of that. We have other factors which are probably not good. So plant-based protein will always the better one. If they are not adequate, then go for whey protein, which come as supplements. Also, now we have a lot of talk on hydroxymethyl butyrate, because we know that leucine is one of the very important amino acid that is important for preventing sarcopenia. And one of the dietary supplement that is available in the market is called beta hydroxymethyl butyrate, which are available as capsules, which helps in decrease the proteolysis and muscle damage during exercise training. This is not for all. This is only for those people who, despite all those traditional methods, they are not able to improve their muscle mass. Probably taking this is much good. This is also available in milk. So only thing is that you will have to take liters of milk to get the same 3 milligram per day of leucine, that is the RDA. So milk is another important, and it's also seen in probably in meat. Unfortunately, red meat has more of leucine than the lean meat. So what happens to osteoarthritis? So in osteoarthritis, I think patients with osteoarthritis have barriers such as pain that could limit their capacity to perform. So when you're doing resistance training, probably you should not put too much of stress on the weight-bearing organ which has gone into osteoarthritis, whether it is a knee or ankle. So aerobic exercise could include some brisk walking or hydrotherapy. So in these patients, probably the swimming or walking, even if you don't know swimming, just walking in a swimming pool, in the shallow part of the swimming pool, is one of the good exercise, because you are walking with the water as a resistance. That gives you count your steps while walking. That comes to aerobic, as well as it also includes resistance, both in one go. So aerobic exercise, definitely it should not be an excuse for a person to with mild osteoarthritis not to walk. They should still be walking 150 minutes per week of moderate intensity. Here, flexibility exercise should be performed to maintain the range of motion. The less we walk, less we do, our, for example, frozen shoulder will become much more stiffened up. So the flexibility exercises are much more important to prevent the periarthritis that also comes with aging. And we physicians, we always have because of our sedentary nature, this periarthritis probably sets in, or diabetic chorioarthropathy. Almost 50 to 60% doctors also have dysglycemia or type 2 diabetes, so that also sets in much earlier. So neuromuscular training is very important component exercise. So probably one leg stand for at least 15 to 30 seconds with eyes open is very important for balancing. So balancing is very important. Even yoga, when we talk about yoga, that you can do it at in your own practice, in your clinic, is also very important as a kind of stretching exercise. Tai Chi and yoga are very important. That can be done with the yoga coming into prominence with the current regime, and there is a lot of, there is a lot of fanfare on the yoga day. I think we should all embrace our own cultural way of doing, taking yoga. And there are a lot of asanas. So I think you require probably a good yoga teacher to find out what would be the best for you. And you don't require any equipment except for a yoga mat. You don't require anything more. So which can be done within the your clinic. So whatever I'm saying is which are probably doable for any physician. Just that the procrastination should be off. So, and now we always talk about we do a lot of exercise, we do a lot of intermittent fasting, we reduce weight. But later on, our body also starts readapting, our BMR changes. So exercise, on incremental exercise is very important to prevent the weight regain after our intermittent fasting is over, or whenever we reach a plateau phase, and then we start probably regain. Same happens with bariatric surgery. There is always a weight loss, and after then there is a plateau, and then slowly these people after post bariatric surgery, they probably start regaining of weight because of their body readapts. The new BMR pushes for weight gain. So I think exercise definitely helps in preventing the weight regain. So last slide, probably how to keep the doctors motivated. Always start with what you can do. So let us not have very too ambitious a goal. So start with which you can enjoy. The key word for my talk, take home message is that you should enjoy what you're going to do. And at the end, you should not be huff and puff, and you should not, that should not be a fear factor. So it can be walking, it can be biking, swimming, and slowly start ramping the mileage and build exercise into your day. For example, you can, if you have pets at home, take the dog for a walk. So that can probably add on at least 300 to 400 steps instead of asking your son or a grandparent or the caretaker at home to take the pet for a walk. And probably you can, do your clinical timing in such a way that you always take some time for the pets, because that keeping pets at home definitely are going to be a lot of stress busters, and you can use them for your incorporate in your physical activity. And always, as I said, take stairs instead of elevator. And there are a few of my friends who also, they walk to their clinic instead of, if the clinic is close by, is probably the next street. And nowadays with traffic too much, metro work going on, taking the car and parking it there somewhere different, far away, everything takes more time. So probably taking a walk to the clinic is good, or even cycling, provided that it suits your style. Otherwise, I think walk is much better off. As I said, exercise snacking can always be done. Always find a person, a close friend, a buddy. So we've always have run buddies, because somewhere down the line we form a club. There will be a runners club. And when you go to gym, you meet people, you start socializing. Always find a person who has a like-minded approach, and they will start motivating you. They will ask you why you didn't come for that particular day. So this motivation is very important during the initial period of time till it becomes a habit. And realistic goals are always important, and definitely keep this as a priority. So prioritize this in your schedule. Instead of just looking at how many patients have been today, appointment is there, see whether I can incorporate some kind of exercise snack between patient 5 and patient 6. See that kind of, the priority, and make it as a non-negotiable. So that is very important. So let's not cheat on those days, especially during the initial part. And definitely we should track the progress, keep a journal where how much we did. And now we have a lot of apps where they can track our workouts. So you have Strava, you have Garmin. So there are a lot of places where you can jot down your workout so that you know how much you have progressed. So after 6 months, after 3 months, after 6 months, after 9 months, and after 1 year, you can see the improvement that happened. And that will definitely motivate us. So we have taken this journey so far. There's no way of looking back. And you can mix it up with all type of exercise. It should not be always a treadmill. It should not be always one kind of exercise. So ultimately, it is enjoy and to prevent boredom. So first and foremost, when some of my doctor colleagues ask me, which is a good treadmill to buy? I said that please don't buy a treadmill, because ultimately it becomes a costly equipment. We start hanging, you dry your clothes. It becomes a kind of a very costly hanger. So don't buy a treadmill. Always try to go buy a good shoe. Probably that will be an answer rather than buying a very fancy and costly equipment. And this is walk the talk. So this is kind of exercise prescription I give for my patients. This is probably, today's prescription, which I have given for one of my patients. So you make sure that when you write a prescription of exercise, make sure that there is a frequency mentioned, intensity mentioned, time mentioned, type mentioned. And these are the things that we need to explain to ourselves. So when we are doing it, it becomes much easier for me to explain. So I hope that this talk would enlighten a lot of people hearing this and probably incorporate into your day-to-day activity. Thank you for your patient listening.
Thank you, sir. Thank you very much for the wonderful advocation on exercise for the doctors. You rightly said, sir, doctors are a vulnerable population for all the complications. Among the vulnerable predisposing factors, aging also is the important factor. We know that we have different type of aging. We have chronological aging, we have biological aging. But aging is not modifiable. Chronological aging is not modifiable, but we can do the modification of biological aging by means of appropriate exercise regimen so that we can reduce the oxidative stress and all, we can prevent the complication also. So exercise plays a pivotal role in all the levels of prevention, like primordial prevention, primary prevention, and secondary prevention. You nicely alluded on the fit concept, that is on frequency, then our intensity, the type of exercise, and also the time of exercise. So I have a doubt, Professor Kumar, sir. So what are the screening protocol we want to implicate in among the doctors before initiating any exercise?
So by the time a doctor realizes that he has to exercise, probably he would have crossed his mid-40s or he'll be in early 50s. So definitely a cardiovascular screening is important, especially if he's having blood pressure. I think a treadmill exercise would be, and resting ECG and treadmill would be better. Definitely, if he is diabetic, I think retinopathy should be looked into consideration, glaucoma. So because when you're doing resistance training, we should not induce anything that can harm a person rather than improve. So probably a doctor knows what is best. Osteoarthritis, if he knows, then he knows which are the joints he should not put too much stress on. So the usual tests that we do for our own annual checkup that we do ourselves will give a clue of what we are. But when it comes to type 1 diabetes, it's all a different ballgame together. We have to make sure that sugars are always on, because we do have a lot of type 1 diabetes taking into exercise program very well, and we have marathoners who are type 1 diabetes. So, and I do have a doctor also who is a type 1 diabetic who runs half marathon. So nutrition is very important. So taking care of your sugars, taking care of blood pressure, and making sure that all the medications are taken at the right time. And very important is sleep. So most of the doctors have a very busy practice that by the time they come home and hit the bed after looking at their email, it is almost past midnight. I know a doctor in Trichy that whose practice goes up to, it probably starts at 12 midnight and goes up to 3 a.m. So these are the people who are will go on to undue stress without their knowledge, and they have a sudden cardiac arrest. So no exercise, screening protocol will help you. So sleep is a sacrosanct for any person, especially for doctors.
Sir, you know that, sir, regarding the we are in the era of precision active prescription. So the exercise regimen should be implemented by single or any combination of both aerobic resistance, flexibility, and balance. So what are your views on that, sir?
It's always going to be combination. Every resistance exercise and aerobic exercise, flexibility exercise, neuromuscular training, all have their own important role to play. Unless until we combine them, we will not get the holistic improvement that we're looking for. Because every domain, aerobic air exercise does not address sarcopenia. So resistance exercise does not address cardiorespiratory fitness per se. So stretching, if you're not done, we are going to develop stiffness, and we are going to develop muscular injury. So everything is should be incorporated for doing exercise.
So lastly, the AD and ESA consists are given finally on 5S: sitting, sweating, sleep, stress, and strengthening. Any message we want to render to our doctors here, sir?
Yes, think we need to practice what we preach. So that would be the best thing. And doing that, there will be a lot of challenges. By then, we also will become empathic to our patients who are actually overweight and obese. So when we have so much, we are not able to do it. Our language, what we speak to our patients also will change for sure.
Yes, sir. Thank you. Thank you very much, sir, for the wonderful guidance and advocacy. Thank you very much, sir. Over to our organizing team.
Thank you, sir. A very interesting case presentation by Dr. S.K. Singh, sir, and very motivating presentation by Dr. Kumar. I congratulate you for such wonderful presentations. I invite Dr. Amit Gupta, sir, to say a few words and propose vote of thanks.
Thank you, Dr. Preeti. First of all, let me thank Dr. S.K. Singh, Dr. Kumar, and Dr. Kannan. I really enjoyed the session and it was very, very insightful. Dr. S.K. Singh, your case was something I think is an eye-opener for all the early career physicians, and it gives us, we need to learn again and again, and it is always wise to revisit something which we often forget. And your case actually highlighted the rare cases like fungal infections and how to investigate and how to navigate the complex diagnosis of such rare diseases. And you are quite right that the diseases may not be that rare, but sometimes we are not able to reach to that level because sometimes we don't think from that point of view. So I'm really grateful to you for your lucid presentation. And Dr. Kumar, again, I learned a lot about the exercise. You are an example, living example of how to do an exercise and how a doctor should be doing an exercise on a regular basis. And I'm sure a lot of people, a lot of doctors among the community, they look up to you as an idol, and they would like to be like you. They may not be running marathon, but they may be engaging themselves in physical activity. And I'm sure your talk has at least inspired dozens of physicians today to start some physical activity. And Dr. Kannan, I am again very thankful and grateful to you because you have profound knowledge. You could ask relevant questions. You can bring out the relevant points with your wisdom and discussion. So I'm again very, very grateful to you. And to Dr. Kumar, I would just like to suggest a thing. It just came to mind. We have many WhatsApp group and we have many other groups. So maybe it's time that we can have our own exercise group where we include people who are doctors, maybe any stream, any exercise. There are many groups I know which are existing, but probably I am not aware in our own circle. So probably you can take a lead and do that kind of thing also.
Dr. Amit, I suggest you, and I keep repeating it, sorry for that. All RSSDI or Diabetes India, any program, please include a 3K walk on one of those days of conference days. So certainly, that's the only way that we can get our.
Wherever I have a say and wherever I can do, sir, I will definitely give that suggestion.
I know that you are a person who is a go-getter. I know that you will do it.
No, sir, I will definitely keep that in mind. And let us take this forward. And Dr. Preeti, again, thank you for setting all this up. And Dr. Preeti is handling this ECP case files for last 6 months, and she is doing amazing work. Thank you for all the work you do for the American College of Physicians India chapter. And with this, we would like to thank, and I'm always grateful to Dr. Anuj Maheshwari, because without his wisdom, without his guidance, it is not possible to set up all these talks and webinars. So again, a big thanks to Dr. Anuj Maheshwari, sir. So I am sure Dr. Preeti must be thinking something very, very interesting for the next episode of Acp India Case Files when we meet next week. Till then, thank you very much, and good night to all of you.
Thank you, sir. Good night.